You probably recognize the gram-positive cocci in clusters. Today we'll be talking about medical treatments for Staphylococcus aureus. There's been a good bit of development. Won't talk about diagnosis, length of treatment, surgical treatment, though surgical treatment is very important. Need to drain abscesses in debris infected devitalized tissue, and if medical treatment fails, you may need to remove cardiac vegetations. Won't talk about Synarcid and Teicoplanin. We'll not talk about Enterococcus or other organisms. We'll be concentrating on Staphylococcus aureus today. Endocarditis and osteomyelitis are two infections that I will concentrate on. These need weeks of treatment. There's potential for death or disability with these two infections, and every case is different. So that need to know the possibilities of a treatment and be able to individualize. For all the drugs mentioned today, most strains have been susceptible in vitro. The very few I'll mention where that's not the case, I'll say so clearly. There have been resistant strains to all the drugs I'll mention today. They have all been reported effective in experimental animal models, so I won't go over experimental animal models today. There have been case reports of successful human treatment with all of these drugs, and there have been case reports of failure with all these drugs. I haven't found any of these drugs for Staph aureus to be 100% effective. Okay, the LSU antibiogram here for 2016 last year, 49% of the inpatient Staph aureus were methicillin resistant. The beta-lactam drugs work against cell wall assembly. Main adverse effects include allergy and GI. This is Nafcillin, the basic penicillin with this big group over on the left. And here is Cefazolin with blocking groups on both sides. Penicillinase resistant organisms, what we call the penicillin resistant Staph aureus, make beta-lactamase. And those groups put on the Nafcillin and the Cefazolin block the action of the beta-lactamase enzyme. Methicillin resistant Staphylococcus aureus, by contrast, change the penicillin binding proteins. When I was a medical student, I thought, what a stupid thing to do. Why would a bacterium make a protein to bind penicillin? Well, that's just what we called them when we first discovered them. Fed radioactive penicillin to organisms and see where it would bind and call those penicillin binding proteins. Actually, they're important regulatory enzymes involved in cell wall synthesis. And penicillin targets them, but the methicillin-resistant Staph aureus have changed those, at least penicillin binding protein number 2. They changed it from 2 to 2A, and until very recently, available beta-lactam drugs bound poorly to penicillin binding protein 2A. We'll be talking about the new exception, Ceftaroline, a little later on. This is Vancomycin, which was the classic drug and remains the classic drug for the methicillin-resistant Staphylococcus aureus. It also works against cell wall assembly. And this was one of the early studies for Nafcillin versus Vancomycin for susceptible Staph aureus to see is Vancomycin as good as Nafcillin for susceptible Staph aureus, and the answer is no. That if your Staph aureus is susceptible to the beta-lactams are better. This was Nafcillin versus Vancomycin. No failures in the Nafcillin group. 19% failed in the Vancomycin group. These were sensitive endocarditis, methicillin sensitive. With Vancomycin, there was a 38% failure rate. With historical controls that had been treated with Nafcillin and tobramycin, only a 6% failure rate. And Here's another beta-lactam versus vancomycin. This was Staph aureus bacteremia. Some of them had endocarditis. With beta-lactams, a 24% mortality. With vancomycin, a 41% mortality. So no, you don't use vancomycin if your isolate is susceptible to methicillin and related penicillins and cephalosporins. This is cefazolin versus vancomycin. Again, cefazolin, a 13% failure rate. This is hemodialysis-related bacteremia, and often get Staph aureus infecting the hemodialysis excess. 13% failed in the cefazolin group, 31.2% failed in the vancomycin group. Here's Staph aureus osteomyelitis. Again, these are susceptible, methicillin susceptible, and this is looking at relative risks. They defined the relative risk of oxacillin as 1, cefazolin it was 1.1, ceftriaxone it was 0.8. That's quite convenient if you've got a susceptible osteomyelitis. You can treat it at home with ceftriaxone once a day. That's if it's susceptible. With vancomycin, relative risk was 2.5. So again, if your isolate is susceptible to the beta-lactam drugs, vancomycin is not the drug of choice. Now, so beta-lactams are better for vancomycin for the methicillin-susceptible Staph aureus. What about the methicillin-resistant Staph aureus? We often take vancomycin for granted and kind of down it, but it was in its day, it was the only answer for these. This is a survival with methicillin-resistant Staph aureus septicemia. This is back in 1985. Inadequate treatment, only 7% survived. No treatment, 17% survived. Clostridium, alone or in combination, nobody survived. Non-vancomycin treatments, amikacin, 42% survived. Amikacin is a sort of a middling treatment for Staph aureus, not nearly as good as the real treatments for Staph aureus. All the non-vancomycin treatments, 50% survived. Okay, vancomycin, 78% survived. So if you've got a beta-lactam resistant Staph aureus, until very recently the beta-lactams would not work, you had to use vancomycin, and we've got some other alternatives now. But it's clear that if you've got a methicillin-resistant Staph aureus, until Ceftaroline came along, no beta-lactam drug was effective. This is Staph aureus bacteremia, comparing oxacillin-sensitive treated with a beta-lactam versus oxacillin-resistant treated with vancomycin, and you come out about the same place. 70% for the oxacillin-sensitive treated with a beta-lactam, and 74% for the oxacillin-resistant treated with vancomycin. So, vancomycin is not ideal, but it has by far the most clinical experience behind it, and I think it's still the drug of first choice. All right, first dose. These were MS-susceptible bacteremias, and some of them had endocarditis. These are looking at the mortality rate. If your first dose was a beta-lactam, the mortality rate was just 11.4%. If your first dose was vancomycin, 39.3%. So if your patient is seriously ill and you don't know the susceptibilities yet, start them both. Start nafcillin and vancomycin and stop the one you don't need when your susceptibilities come back. What about the aminoglycosides? Questionable effectiveness alone. They're okay, but they're certainly not first choice drug for Staph aureus. Controversial for deep infections without a foreign body, that's adding them. In vitro and in vivo results were variable, and even a 4-day course increases the risk of kidney toxicity. However, rifampin, not effective alone. If you give it alone, Staph aureus quickly develops resistance. It may help in combination for colonization and recurring skin infections. Controversial in deep infections without a foreign body. In vitro and in vivo results are variable. If there's a foreign body infection, it does help. Our Anti-staph, the top of the ticket drugs, don't get up against foreign bodies very well. They don't get into biofilms that well. Rifampin gets into biofilms just great. So add rifampin and also add gentamicin to discourage development of resistance in foreign body infections. Empiric evidence is weak and mainly extrapolated from staph epi, so we're not really sure they help in Staph aureus, but we think they might if there's a foreign body. And I think it's reasonable to use them with a foreign body until further research. Current recommendations are to give rifampin for the whole course if there's a foreign body involved. Of course, the best thing is to get the foreign body out of there, but if you can't, give rifampin for the whole course. Give aminoglycoside for the first 2 weeks. Be watching the BUN and creatinine. Okay, if there's no foreign body, there is no consistent evidence for adding either gentamicin or rifampin to the primary drug. So if you don't have a foreign body, don't add these guys for Staph aureus. Okay, treatments for methicillin-resistant Staph aureus. Okay, first the glycopeptides. Vancomycin, and for comparison, I'm going to mention the doses for skin and skin structure infections. That's, for some of the newer drugs, that's all that's been developed. If you want to use them for endocarditis or osteomyelitis, some of the newer ones, then you have to make up your dose, hopefully based on some review of the literature. And of course, I will be talking about unapproved indications for a lot of drugs today, but nobody paid me to do this, so it's my own opinion. But for vancomycin, for skin and skin structure infections, the dose is 1 gram IV twice a day. Maximum concentration at peak is about 63. MIC 90 is equal to or less than 4. There has been some variability with vancomycin. Now, there's been some controversy about vancomycin MICs up to 2. There was some work that seemed to say that the patients didn't do as well, but some later work says they do. So there's no reason to stop vancomycin just because the MIC is 1.5 or 2. Go ahead and try it. If you fail, you fail. The MIC, the antibiogram here at LSU, 100% of the vancomycin isolates were susceptible last year. There's some new glycopeptides, telavancin, dalbavancin, and orbitavancin. These are like the vancomycin molecule with added hydrocarbon side chains. They have longer half-lives and lower MICs for methicillin-resistant Staph aureus. Telavancin, the skin and soft tissue, skin and skin structure infections dose is 10 milligrams per kilogram IV daily. It comes in a 750 milligram vial, which would be about right for both your patients once a day. Peak concentration 93. MIC is lower, equal to or less than 0.12. Dalbavancin, dose for skin and skin structure infections is 1,500 milligrams single dose. Peak is 423, MIC 90, less than 0.25. Oritavancin, dose 1,200 single dose, peak 138, and MIC 90 less than or equal to 0.12. So for these newer ones, you've got an enormous spread between the MIC and the peak. Telavancin has been used clinically, and there's some small series of successes in both endocarditis and osteomyelitis. For dalbavancin and oritavancin, I was not able to find any human work with either endocarditis or osteomyelitis. All three of them do work in skin and skin structure infections. For the lipopeptides, one that's available now is daptomycin. The skin infection dose 4 milligrams per kilogram IV once a day. Peak concentration about 58. MIC 90, 0.75. Okay, here's the daptomycin molecule. It's again a big ring molecule. And it targets the plasma membrane, not the cell wall, but the plasma membrane. Adverse effects include skeletal muscle toxicity, so you need to be asking about muscle soreness and monitoring the CPK. Less of a risk if it's given once a day. And for more serious staph infections, 6 milligrams per kilogram per day. This is for bacteremia. This was this started out as one of these get it through the FDA studies, but it was a good study. This was by Fowler and others in the New England Journal of Medicine in 2006. For all cases of bacteremia, some of which had endocarditis, this was daptomycin versus standard therapy, which could be either beta-lactam or vancomycin. 44% in the daptomycin group versus 42% in the standard therapy group. If you dissect out the endocarditis cases, almost 47% of the daptomycin cases were successes versus 31% in the standard therapy group. This showed non-inferiority, did not show superiority, but showed they're comparable. Okay, here's a smaller study, 5 cases of osteomyelitis who had either failed vancomycin or could not tolerate vancomycin. 4 of the 5 resolved with daptomycin, 1 relapsed. Okay, the oxazolidinones, linezolid has been around for a while. Tadizolid just came out. With linezolid, the dose for skin infections and just about all infections is 600 milligrams twice a day, whether it's IV or oral. This drug is very well absorbed orally. In fact, the peak I'm sorry, I hit the wrong thing. Peak concentration IV was 12.9. Peak concentration orally was 12.7, which shows you how well this medicine is absorbed. MIC 90, that means 90% of strains were inhibited by concentration of 4 micrograms per milliliter. Here's linezolid. It targets protein synthesis. Adverse effects include nausea, vomiting, and diarrhea, and it's notorious for decreasing the platelet count. You've got to be watching the CBC. This isn't a you prescribe them a bottle of pills and send them home and don't see them for 6 weeks drug. You probably have to see them every week. Ask them about diarrhea or any other complaints and check the CBC. Before we knew about this, there were some well-documented deaths from cerebral hemorrhages in patients whose platelets fell out. So you got to be watching it. They also can develop anemia and rash, but the real problem is platelets. Okay, for Staph aureus endocarditis, in an early study by Birmingham and others in 2003, linezolid cured 4 out of 4. And same author with osteomyelitis, it cured 13 out of 16 cases of osteomyelitis. A larger series of 18 cases of methicillin-resistant Staph aureus endocarditis reported by Aureus in 2006. 18 endocarditis cases, 10 were cured, 5 failed, and 4 of those died, 3 unevaluable. This is for endocarditis, vancomycin indeterminate, so these people had a little higher than 2 MICs for vancomycin. This patient had an AICD, one of those implanted defibrillators, got a bacteremia, was treated 3 weeks with vancomycin, did all right, stopped the vancomycin, he relapsed. And this time, they found vegetations on both the aortic and the mitral valves. Vancomycin MIC had started out 2 or less, but when they rechecked it after the relapse, they got anywhere from 6 to 8. So this is definitely a decreased susceptibility of vancomycin. Cured him with Linezolid IV every 12 hours for 67 days. Okay, osteomyelitis. This was a series by Rayner of 23 cases. 70% were cured, 26% failed, and 4%, just the one case was indeterminate. Couldn't definitely say. Okay, so Linezolid has had some solid evidence behind it that it is a viable treatment for methicillin-resistant Staph aureus serious infections. Tadalafil just came out, skin and skin structure dose 200 milligrams a day, either IV or PO. Again, it's very well absorbed. The peak concentrations are about the same orally or IV, 2 orally, 2.3 IV, MIC 90 equal to or less than 0.5. Okay, beta-lactams. Got a new beta-lactam. Okay, Ceftaroline. Ceftaroline has higher affinity for penicillin binding protein 2A than the previous beta-lactams have had. For a 600, the dose for skin infections was 600 milligrams IV twice a day. The reports of using it for endocarditis, they've used it 3 times a day. Again, there is no standard dose for endocarditis, but if you want to treat endocarditis, I'd recommend, I would agree with 600 3 times a day. With the 600 milligram dose, peak is 19, MIC 90 equal to or less than 2. Here's the ceftaroline molecule. You can see the basic cephalosporin nucleus with groups on both sides of the molecule. Okay, this is ceftaroline for MRSA, endocarditis, and osteomyelitis, and all of these patients had already failed vancomycin. Endocarditis, it cured 4 of 5 patients. Osteomyelitis, it cured 2 of 2 patients. Okay, macrolides. Erythromycin and all the erythromycins, including azithromycin, clarithromycin, all those have not been effective at all for the methicillin-resistant Staph aureus. How about clindamycin? Skin and skin structure dose was 600 milligrams 3 times a day, either IV or PO. Peak concentration for IV at this dose was 10.8. I wasn't able to find a PO one, but all my references said that it's very well absorbed, so PA will probably be slightly below that. MIC equal to or less than 0.5. The LSU antibiogram for last year said only 68% of the Staph aureus, the methicillin-resistant Staph aureus isolates were susceptible to clindamycin. Okay, here's clindamycin. Okay, it targets protein synthesis. The big adverse effect is diarrhea. Some of the most serious of these are Clostridium difficile, but it has other ways to cause diarrhea also. So diarrhea is a big problem. You got to be asking about it. Of course, it's the most likely to cause pseudomembranous colitis of all antimicrobials, and it can cause rashes. Okay, here's a case of endocarditis. The clindamycin was tried and failed. This is a 42-year-old addict, tried clindamycin's 600 IM every 6 hours, got an initial response, but 26 days into treatment relapsed. The Staph aureus became resistant. The MIC rose from 0.1 to 3.2, was cured with Methicillin and gentamicin IV, followed by Clostridium PO. This was reported way back in 1976, and there hasn't been much enthusiasm for treating endocarditis with clindamycin since this abject failure. How about clindamycin for osteomyelitis? Gets used a lot in children. This was a study in children of Methicillin versus clindamycin. The Methicillin for 4 weeks, then dicloxacillin for 4 weeks versus clindamycin for 6 days, followed by clindamycin for 5 weeks. 77% in the Methicillin group, 92% in the Clindamycin group. So in children, it's a great drug. This was clindamycin for bone and joint infections, 54 patients, both children and adults. 87% had a satisfactory response. 3 patients had diarrhea, but none of them had pseudomembranous colitis. This was back in '77. Why don't we use it in adults? Because the older you get, the higher your risk of diarrhea. This was, here is, this is, they defined relative risk as 1 in the 18 to 40 group, 41 to 60, 6.64, 61 to 75, 11.77, over 75, 14.3. So if you're over 75, you had 14.3 times the risk of somebody who was 18 to 40. Many of our patients with osteomyelitis are up in age, and we're very reluctant to try to use clindamycin for them. They're better things, less risky things for us to use. How about the tetracyclines? Okay, target protein synthesis, adverse effects, nausea, vomiting, diarrhea, dizziness, photosensitivity. Okay, here's the basic tetracycline molecules, and there have been a lot of variations in the substitutions on the 4-member ring. Here's minocycline, which is much more effective for Staph aureus. Here's tigecycline, which is even more effective for Staph aureus. It has an amino acid chain, glycine, hooked onto the basic tetracycline molecule. Okay, tetracyclines for MRSA. The tetracyclines are pretty variable. Tetracycline itself pretty variable in the MIC for Staph aureus, methicillin-resistant Staph aureus, anywhere from 0.25 to 128. But to get 90% of the strains, you'd have to be up at 128. So plain old tetracycline, not a very good choice. For minocycline, much better, MIC 90 at 8. Tigecycline, MIC 90 at 0.5. Okay, tetracycline, we just here do a class disc for tetracycline. For MRSA here last year, 97% sensitive for tetracycline for the class. Minocycline, the skin-and-skin structure dose, IV or oral, is 100 milligrams twice a day. Cmax, after a 200 milligram dose, higher than that recommended dose, is anywhere from 2.1 to 5.1. Okay, here's a case report of a success for endocarditis with minocycline. This was MRSA endocarditis. Started out treatment with vancomycin, rifampin, and gentamicin, failed. Then tried trimethoprim sulfamethoxazole, Bactrim. It failed also. Then put him on IV minocycline, and it cured him. Had to go on for about 6 weeks, and this was intravenous minocycline. Okay, tigecycline, skin structure dose 100 milligrams load, then 50 milligrams twice a day. Get a good bit of vomiting with tigecycline. Cmax was 1.45 after a 100 milligram dose, 0.87 after a 50 milligram dose. Are blood levels important? For most infections, probably not. You're probably concerned about tissue levels. Endocarditis is an exception because the capillaries don't get into vegetations. You've got to rely on the drug that's actually in the blood to get into the vegetation. So yes, for endocarditis, blood levels do matter. Blood levels aren't very high for tigecycline. There's been some preliminary series showing higher mortality with tigecycline than with comparator antibiotics. So tigecycline's sort of on hold now until we find out a little more about it. Okay, folate antagonist, trimethoprim sulfamethoxazole. This is Bactrim. The double-strength pill and the IV vial both contain 160 milligrams of trimethoprim and 800 milligrams of sulfamethoxazole. By the antibiogram here, 98% of our methicillin-resistant Staph aureus inpatient were susceptible to trimethoprim sulfamethoxazole. So it's an old drug, but neither the tetracyclines nor the trimethoprim sulfamethoxazole deserve to be forgotten about. Okay, both these drugs target folic acid synthesis. Adverse effects include nausea and vomiting, also diarrhea, allergy, both rashes and drug fevers. Okay, here's sulfamethoxazole, basic sulfonamide molecule with some substitutions, and here's trimethoprim. Okay, this was an earlier study from 1992 by Markowitz and others. 101 Staph aureus infected patients, nearly half had MRSA, 23% had tricuspid valve endocarditis. Trimethoprim sulfamethoxazole IV cured 86%, vancomycin IV cured 98%. So it was okay, but no match for vancomycin. Okay, this was Staph aureus osteomyelitis. Most of them were Staph aureus, not all of them were Staph aureus, most of them were. They were treated with a combination of trimethoprim sulfamethoxazole and rifampin, cured 20 of 21 patients. Okay, on to the quinolones. As of about 5 or 6 years ago, there was still some enthusiasm for the quinolones for Staph aureus. Even back when the quinolones first came out, most Staph aureus were susceptible to them. That's gradually changed, and now Staph aureus, more and more of them have developed resistance, and quinolones are no longer a reliable treatment for methicillin-resistant Staph aureus. By the antibiogram here last year, only 45% were susceptible to levofloxacin and only 39% to ciprofloxacin. So there are many organisms for which the quinolones are excellent drugs, but not Staph aureus. Okay, relative costs, and I found this interesting. These were based on acquisition cost. And Mr. Skates in the pharmacy helped me with this. This was as of yesterday, and acquisition cost is complicated. And this was at the recommended dosing for skin and skin structure infections, since for the newer ones, there is no recommended dose yet for endocarditis or osteomyelitis. And this was to treat skin and skin structure infections for 1 week. All right. And I did it for acquisition cost for this hospital and for skin and skin structure infections, because that would allow me to compare the drugs with each other. Okay, cephalexin orally, 500 milligrams 4 times a day, $3.08. Dicloxacillin orally, 250 milligrams 4 times a day, $11.20. I'm sorry. Yeah, I'll get used to this someday. Ceftriaxone IV, the price has come way down on that. This was 1 gram IV daily for 7 days, only $18.06. Clindamycin orally, this was 600 milligrams 3 times a day for 7 days, $28.14. Trimethoprim sulfamethoxazole double strength, 1 pill twice a day for 7 days, $49.28. Vancomycin IV, really quite cheap. This was a gram twice a day for 7 days, $65.94. So pretty cheap. Now this doesn't count the nursing time, the diluent, or the IV tubing or any of that. This is just the drug. Clindamycin IV, about 133. Cefazolin IV, about 153. Trimethoprim sulfamethoxazole IV, 163. Trimethoprim sulfamethoxazole's quite well absorbed orally. So if your patient can take an oral medicine, you can probably give it orally. Though if it's a serious case of endocarditis, you may be nervous about that. You want to give it intravenously. Okay, Methicillin IV, you have to give 2 grams 6 times a day, so that was up at $303. Linezolid IV, $538. Linezolid's extremely well absorbed. Not a whole lot of reason to give it IV, though you might be nervous in a serious endocarditis case. But if it's not a really serious case and your patient's got a functioning GI tract, much cheaper to give it orally. Now we start getting to the really expensive ones. Okay, the new glycopeptides, dalbavancin IV, this was for the big single dose, for about $14.26. Tadizolid IV, this is the new oxazolidinone, like linezolid, almost $1,480, both orally and IV. Minocycline IV, PO, you had a question?
Yeah, is this for the full 2-week course?
For 1 week. Yeah, had to do something I could, where I could compare them. So this is a 1-week course at the dose that's recommended for skin infections. So yeah, Tadizolid and about 1470 to 1480 for either IV or PO. Minocycline IV, 1970. Minocycline PO was pretty cheap. Minocycline IV was quite expensive. Ceftaroline IV, about 2070. Tigacycline IV, way up there, 2,225. And the new glycopeptides, telavancin, 2,635, oritavancin, 2,770, daptomycin, 2,985. So daptomycin still comes in as the most expensive. Okay, what about these drugs? Okay, Methicillin for susceptible infections, yes. For endocarditis, yes. For osteomyelitis. Cefazolin, yes. Vancomycin, yes. Daptomycin, yes. Linezolid, yes. Ceftaroline, yes. Telavancin, yes. There's enough small series that I think you can consider it a viable drug for both, for serious infections with both osteomyelitis and endocarditis. Dalbavancin and oritavancin, I think, require more study. I don't think you'd use them for a serious infection now unless you were really backwards up against the wall and didn't have anything else. Okay, Quinolones, no. Clindamycin, no for endocarditis, not for adults. Great for children with osteomyelitis. Trimethylsulfamethoxazole, I think it needs more study before we use it for endocarditis and osteomyelitis. For skin infections, it's great if the bug is susceptible. Okay, minocycline, again, these are fine for skin infections. For tigacycline, I think it's way too expensive and too many side effects to use it for skin infection. Minocycline is fine for skin infections. I think they would require more study before you use them for endocarditis or osteomyelitis, unless it's a last resort. Okay, so my own synthesis for MRSA infections, I'd start with vancomycin. Watch them closely. Be rechecking the blood cultures at 2 days into vancomycin, recheck the blood culture, and also check your trough level. Okay, if you're failing at 3 days, especially if you've got an MIC more than 2, change to daptomycin. Sorry it's so expensive, but it's a good drug. Okay, if you fail both vancomycin and daptomycin, possibilities include 1, adding ceftaroline to daptomycin. There's some in the test tube evidence and also a small series that showed improvement if you add ceftaroline to daptomycin. Another possibility is just stop daptomycin and change to ceftaroline, or stop daptomycin and change to linezolid. And it would be individual considerations that would decide which substitution you make. Yes?
What would your criteria for failure be after 3 days?
Okay, that would be your overall assessment of the patient. Is the fever coming down? Does the patient feel better? Like if it was osteomyelitis, is the pain any less? If it's endocarditis, is the patient any less short of breath? And what the blood culture is showing. If the blood culture is still positive, but the patient has defervesced and feels a whole lot better now, I might continue it and see maybe 4 out of 4 bottles were positive at baseline, now 2 out of 4, then 2 days later it'll be 1 out of 4, then it's negative. So I think you have to put the whole case together and decide whether you think the patient's failed yet or not. Okay. Okay, and that's all, folks. Questions? Yes.
For the
Ceftaroline, yes.
For pneumonia, specifically staph pneumonia, would you consider using that orally for staph pneumonia?
Ceftaroline won't work orally. It's not absorbed. It only works IV. If you want an oral drug for Staph aureus pneumonia, you'd go with Linezolid. In some very preliminary work, it seemed to do better than Staph aureus. I haven't seen a prospective head-to-head study, but in some retrospective analyses, it seemed to do better. I'm being a nervous kind of guy, I'd probably start at IV, and if they got better, I'd change to oral for Staph aureus pneumonia. Anything else? Okay, well, thanks for your attention.